Okay.
I'll now move on to introduce Professor Goel. I'm sure that everyone knows Professor Goel. I have had the pleasure and privilege of meeting him many times and attending his lectures. Yesterday I was at a webinar that he was where he was delivering an invited lecture. I tell you, it was just 15 minutes. Already I saw things very differently. Professor Goel doesn't need introduction. He has been a thought leader. We might agree or disagree. We might wait to learn, but certainly he's one of those people who will qualify you. I think Frederick would call him the definition of a genius. Someone who's excellent, can see where the target is and hit it every time. A genius is who can see things that others can't see. So Professor Goel, it's an honor to welcome you to give your lecture.
Can you see my slides?
Yes,
Naren?
yes, Professor Goel.
Okay. So it is indeed my great pleasure and honor to be on this very big platform of Listserv with Naren and with various leaders in the subject. And I'm going to take you to my world of Atlanto-axial instability. Atlanto-axial instability is quite, I must say, and I completely believe in this fact, that Atlanto-axial instability is the most common form of instability in the entire spine. Atlanto-axial instability is the most under-recognized clinical entity. Atlanto-axial instability is the most under-treated clinical entity. So I want to introduce this entity first, and then I want to show one case where I will like to demonstrate how I do it. See, these kind of short neck, twisted necks with limb problem, weakness of the hands, weakness of the legs, you can give new life to these people. You can give completely new life and a new neck to these people, new hands, new legs. There is one bottom line, and that bottom line is, can you do Atlanto-axial stabilization? If you can do, you can give new life. The question is whether difficult operation. This is the beautiful Atlanto-axial joint. This is the most mobile joint of the spine. Occipito-atlantal joint is the most stable joint of the body. Junction. Largest transverse process of the whole body. This transverse process is the largest in the entire spine. This spinous process of C2 is the largest spinous process of the whole spine. This atlas facet is the strongest bone of the whole body. If you touch the facet, you will not see any bone which is as strong as the facet of C1. You see, this is the superior or the rostral aspect of C1 facet, and its number of ligaments attached here, space for ligaments. This makes occipito-atlantal joint the strongest. And if you see the undersurface of the facet, there is not one space for the such rigid space for ligaments. This is the flat and round joint. This is the most mobile joint and the most liable joint to become unstable. More the mobility, more the instability. All the movements occur at facet, and all the muscles are pulleys which focus at the facet. So this is one thing we should remember. And if we have to stabilize this joint, we have to stabilize the facets. So this facetal fixation we described in 1987. One screw in C1, one screw in C2, and as you know, this is now a very popular technique of Atlanto-axial stabilization. So this was my first case in 1988. It involves three basic issues without controversy in my mind, without any confusion. Open the joint. Open the joint. This is difficult, but this is the most required thing. Remove the articular cartilage. Absolutely necessary. Introduce bone graft within the joint cavity. Absolutely necessary. And then do atlanto-axial stabilization. Atlanto-axial joint, the posterior wall of the atlanto-axial joint is covered by the ganglion. C2, this is the C2 ganglion. We described in 1988 that you cut the ganglion and you have a panoramic vision to the atlanto-axial joint and you can do fixation. However, more recently, not recently, for at least 15 years, I do not cut it all the time. I will say very infrequently I cut the ganglion, but the possibility to cut the ganglion has opened the window to atlanto-axial joint and opened the window to atlanto-axial stabilization techniques. The other, if you have to do this facetal fixation, lateral mass fixation, this vertebral artery is the most critical point to understand. You see here on the pedicle, sometimes that point again, you see sometimes the vertebral artery as it goes up, it has a very big loop inside the C2. This is the atlanto-axial joint. This is the odontoid process. This loop can create big problems in introduction of C2 screws, but I can say even in this case, it is possible and you must learn how to do it. So in 1988, we divided C2 pedicle. This is the pedicle. This is the pars region. This is the facet in this area. And when you put C2 screw, you can actually damage. So we have divided in 9 quadrants. The upper medial quadrants are the best to introduce the screws. So there is a mobile type of atlanto-axial dislocation. The screws have to be medial and they have to be superior. So this was amongst my very first cases in 1988-89. So mobile and reducible atlanto-axial dislocation, no controversy, you have to do fixation and you have, as we have matured in this business of atlanto-axial fixation, simultaneously the investigations have improved. And this is the 3D model that we now use quite regularly. I will not say always, but quite regularly. You see how beautifully the vertebral artery is seen. More complex cases, I need this investigation almost always in complex cases at least. And you can see by this imaging that you can know exactly where to put the screw, exactly how to save the vertebral artery. And this can be, you know, you can place the model right by your side during operation. You can prepare your surgery and you can do beautiful atlanto-axial stabilization. So this is the most beautiful bone of the body. This is called atypical bone. And if you see, the beauty is, one is the large odontoid process nobody else has. Large spinous process nobody else has. The other beautiful thing is, if you see, this is the superior facet of axis and this is the inferior facet of axis. They are not in line. All other facets, superior and inferior, are in one line, but here the superior facet is in front, inferior facet is behind. So normally I place my screw like this in the superior facet, but when the vertebral artery is in a little bit difficult situation, you can use the inferior facet also to introduce the screw as a salvage technique. So if you see this one screw in C1, you can use inferior facet of C2, this one, to introduce your screw. So here, this is a complex little case, and I have used C1, C2, 3 facet articulation to introduce and stabilize the joint. Vertebral artery, as I mentioned, takes a loop, and sometimes this loop can actually make your this operation impossible. So we had described this technique of mobilizing the vertebral artery and then introducing the screw. You see here, this is quite a huge vertebral artery, so it is very difficult to introduce your screw here. So what we have done is, you see also there is a very thin bone here. You drill this bone, you identify and isolate the vertebral artery, then you mobilize the vertebral artery, and then you can introduce your screw. If you see this image, the vertebral artery has been mobilized, and then you introduce the screw. So after this information that this can be done, believe me, my operation has become much safer for vertebral artery. For a long time now, vertebral artery damage is possible, but it has become less. More we have learned the information about vertebral artery. You can introduce joint jamming technique or these kind of spacers when the vertebral artery's loop is too big and you just cannot do your fixation. These kind of distraction screws or facet spacers are used for various other indications, which I will mention. Like this screw here, this patient here, I was not able to introduce C2 screw because of various reasons, so I have introduced a spacer. You can use in some situations laminar screws or spinous process screws, which we described first time in 2004. Spinal laminar screws, spinous process screws, when you cannot introduce. But I do not use these screws for a long time because with my experience, I am able to do C2 screw in whatever situation. Sometimes I'm not able to do, then I do alternative techniques. So this was spinous process screws that we described in 2004. Atlanto-axial instability is the issue. Occipital is not. Occipito-atlantal joint is the most stable joint. It is almost impossible to destabilize occipito-atlantal joint. So for me, craniovertebral junction instability is equal to atlanto-axial instability. Craniovertebral junction stabilization is equal to atlanto-axial stabilization. Occipital screws were first described by us in 1987. We do not recommend inclusion of occipital bone in the fixation construct. The other thing that we describe and possibly change the face of craniovertebral junction surgery is the issue of fixed atlanto-axial instability. We said that there is no fixed atlanto-axial instability. You can open the joint, distract the facet, and mobilize and reduce the dislocation. So there is nothing like fixed. It is an situation is the issue. Like flexion extension, no change in this movement. Transoral surgery was done all over the world, but we have introduced this concept, open the joint, reduce the dislocation by manual manipulation, and craniovertebral junction realignment was introduced as a form of treatment. So this is vertical instability. Flexion goes in, extension comes down, facetal articulation is the issue. This is lateral facetal instability. This occurs in bifid anterior and posterior arch of atlas, and also in cases of trauma where there is a fracture of atlas, the facet goes laterally. You see lateral dislocation. And when there is lateral dislocation or joint is completely disrupted, open the joint, manually manipulate and realign the facets, and you can do a beautiful realignment fixation. No decompression. No decompression is my key word. Rotatory atlanto-axial dislocation. In children, it occurs, as many of you know. Rotatory atlanto, then doing open the joint, manually manipulate the joint, and reduce the dislocation. Basilar invagination is a complex subject. In 1998, our idea was that this is a fixed atlanto-axial dislocation, type 1 decompression from front, type 2 decompression from behind. This was my article, and this was my conclusion, that these need this kind of decompression. In 2004, we said that a large number of group A patients are unstable and you need to do craniovertebral junction fixation and realignment, and group B, we said that you need to do decompression, and craniovertebral junction realignment was introduced as a form of treatment. So this patient, you open the joint, distract and reduce the basilar invagination. Basilar invagination reduce and realign. Now, these patients where we have done craniovertebral realignment, decompression as a treatment is completely outdated in my, at least in my practice for a long period of time. Basilar invagination, important is you realign the person, you give him new life, you completely give him new legs, new hands, new neck, and new life. The other beautiful thing we identified is the short neck, torticollis, clipple abnormality, platybasia are not embryological problems. They are protective. Short neck is protective. Torticollis is protective. All these are protective against one entity of Atlanto-axial instability. You stabilize and you have, there is a possibility of reversal of long-standing musculoskeletal abnormalities. Bone fusions are protective. This is what we have identified. No question about it. No question. When you see multiple bone fusions, don't think they are abnormal. They are not normal, they are more than normal, and they indicate Atlanto-axial instability. When there is bifid spine, this is not like spina bifida of lumbar spine. This indicates unstable Atlanto-axial joint, and you need to stabilize, and you give instantly new life to these people. These unfortunate people who have difficulty in breathing, difficulty in handling, difficulty in moving. You give happiness, you give smile, you give power in the person. There is no compression at the craniovertebral junction, but presence of these kind of anomalies indicate the need for Atlanto-axial stabilization and a completely new life to these people. I do not want to argue because Naren has given me, and I have to show what I do. But syringomyelia, in my view, is never to be treated by shunts or by any primary manipulation. They are helpful, they are not harmful in any instance. I introduced a new concept of central or axial Atlanto-axial instability. No question in my mind, this has a possibility of completely revolutionizing not only Chiari malformation, not only syringomyelia, but Hirayama disease, OPLL, and cervical degenerative spondylosis. So we introduced three types of dislocation. One is type 1, when the facet of atlas is in front of facet of axis. You can see this. When this happens, there is atlantodental interval is increased, there is cord compression, and there is no argument and no discussion in the world of neurosurgery that you need to do atlanto-axial stabilization. Decompression is not a treatment. Type 2 is when the facet of C1 is behind the facet of C2, there will be no atlantodental interval disturbance, there will be no cord compression, and these patients do not need decompression, these patients need stabilization. There is no doubt in my mind. Now, type 3 is even when the facets are in alignment, even when there is no atlantodental interval disturbance, presence of Chiari, presence of serines is an absolute indication of an unstable atlanto-axial joint. You need to do atlanto-axial stabilization. The question is only one. The question is only one. And that question is whether you can do it. I have to say, despite my experience of more than 30 years, it is still difficult for me to do fixation in cases with serines. In fixation, it's very difficult to do atlanto-axial fixation in cases with such basilar invagination. But that is the treatment, and there is no question about it. Even when there is no atlantodental disturbance, no facetal disturbance, presence of Chiari is a clear indication. We said for the first time that there is small posterior fossa in basilar invagination. There is tight posterior fossa. This was in my article in 1998, but I am now saying there is vertical height is decreased, but transverse height is increased in cases of basilar invagination. Basilar invagination is always associated with atlanto-axial instability, and for both group A and group B, atlanto-axial stabilization difficult in some cases, particularly in group B, very difficult, but we have to learn difficult things in our lives, as we know in neurosurgery. So I have no hesitation to say that we have completely demolished transoral surgery from the domain of neurosurgery. And I have no hesitation to say today that for basilar invagination, for any kind of craniovertebral anomaly, foramen magnum decompression is an absolutely redundant treatment. For Chiari malformation, it is a negative operation. So basilar invagination, syringomyelia, Chiari malformation, Atlanto-axial instability is the cause, and Atlanto-axial instability is the cause of Chiari malformation and Atlanto-axial stabilization. No decompression is the treatment. We know that many kinds of dural decompression, neural decompression, craniectomies have been described. And I do not argue, whoever does, they do. But what I do and what I think is these are redundant and negative operations. So when you see there is no atlantodental interval disturbance, there is some facetal instability, you stabilize. You stabilize and you see wonders, not with the syringe, but with the patient. You see great happiness on the faces of the patient in the evening of operation, like you have never imagined. Syringe will reduce, but whether it reduce or not is not the issue. The patient will reduce in his symptoms and will dramatically reduce in his symptoms. And syringomyelia, if you do scan after 1 year, 100% cases, the syringe will reduce. So now I have got several 100 cases, and recently I reported my series of about 350 cases with Chiari and syringe. 100% result I have reported in World Neurosurgery. You please see that report. And if you see that report, there are only two things that you can do. Is one, you can doubt my results, and second is you can agree with my strategy. So you please agree with the latter. So this is an even when I had described first in 2012 or 13, many pediatric neurosurgeons said that this is not valid for pediatric patients. I introduced another series some time ago of 33 patients. No question, my dear friends, difficult. In children, more difficult to do. This is a child, more difficult to do fixation, but this is the treatment. And you have to realize that decompression is a negative treatment and syringostomy is an absolutely negative form of treatment. So this is a child, I don't want to spend too much on this video, but this child immediately got new life after 3 months, and you can see the smile on the mother's face. This is, I call, divine smile. And this kind of smile you can get only if you do fixation beautifully. Treatment of idiopathic syringe, I do not want to discuss too much about this, and I do not want to contradict what Marcus has said. But I have to say that all cases, whether the syringe is present in the cervical spine, whether the syringe is present in the dorsal spine, idiopathic syringe, you see here my title of my presentation is almost, I'm using that word almost, unless it is traumatic series, unless it is tuberculous series, unless it is arachnoides, those are extremely, extremely rare situation. Trauma you don't need to touch. But syringe, idiopathic, you do stabilization, you give new life. You give absolutely new life. I will say doing shunt for this patient, there is no Chiari, nothing here. You do shunt, you create. I don't want to, you see, Marcus is my great friend and he's a great proponent and a real scientist. I'm not contradicting what he's saying, but I have to say what I am doing, and I do stabilization for this, and I have seen with my own eyes wonders, and I have seen dramas, and I have seen spiritual divine intervention in the evening of operation. Kyphoscoliosis and syringomyelia Chiari malformation is a huge subject. I just want to touch briefly. When there is Chiari, syringe, and kyphoscoliosis, even when there is no Chiari, when there is syringe, you find unstable Atlanto-axial joint, and you can avoid doing all kinds of instrumentation, and you can give a supple, beautiful, fantastic spine with all movements restored in the evening of operation. Central Atlanto-axial instability is a huge, absolutely massive subject. And even in the degenerative spine, you see, when you talk of degenerative spine, you talk of C5, C6, never of atlanto-axial joint, but I am saying atlanto-axial instability or atlanto-axial degeneration is the #1 degeneration of the whole spine, and stabilization. You see multi-level degeneration, you see the central instability, you have to stabilize atlanto-axial joint. Multi-level degeneration, you see the facetal instability, you have to stabilize the joint. Also, posterior atlanto-axial, OPLL, absolutely new introduction in the world of neurosurgery is atlanto-axial instability is very common in these situations and give beautiful results. Otherwise, do decompression from front, do decompression from behind, do decompression from below, do compression negative operation. So now I want to show you, I know it is a difficult technique. I know atlanto-axial stabilization is difficult, but it is possible. I am doing atlanto-axial stabilization for a long time. Just a minute. Just a second, please. Okay, now I will introduce you to a technique. As you can imagine, this is my little bit oldish video, not new video. So this is a 65-year-old gentleman, and he has atlanto-axial instability, and quite a, there is no controversy here in this case, at least, that you have to do atlanto-axial fixation. Nobody will say, I will do decompression, or nobody will say, I will do decompression from here. So there is a clear case of atlanto-axial partially reducible. You see, this is atlanto-axial instability. In extension, it does not completely reduce. So even 20 years ago, I was doing personally decompression for such cases. See the facets are, the joint space is reduced, the facets are in malalignment, and you need to stabilize. There is no question. You see the facet coronal image is always necessary. You have to see the vertebral artery, where it is located, how much closer to the facet joint, and how much deep it is, you have to know, and you have to exactly know. I always do this. You see, this is a little bit heavy patient, as you have seen. Always I introduce Gardner-Wells traction. This is a beautiful traction. No other traction like this. Under GA, I do after the patient is induced for anesthesia. I give this traction, Gardner-Wells traction, and then hold the head in my hand and then turn under my supervision. You see, heavy patient a little bit. Under supervision, I give a prone position, and then I place him under traction. The head is actually, you see, it is floating head. It is touching, but not, you see here, you see, it is just touching the face. It is not, it is actually a floating head. And then what I do is I place the position, protect all the parts, and then take midline incision. And my midline incision is about 4 cm. This is a little biggish incision. I will not take such a big incision now. 4 cm above the spinous process of C2 and below the spinous process of C2. Then my technique is of a little bit different kind. Coagulation does not come into the picture of my surgery. No bipolar, no unipolar comes in my field. This is C2 spinous process. You see C2 spinous process, I have exposed, then I do sharp dissection on the lamina of C2, and then I do dissection in the, this is almost an unedited tape. You must also imagine that. Many of these cases can be done in good half an hour or 45 minutes. Then I go in the lateral gutter to expose the C2 ganglion. There is no need to expose the C2 ganglion in all cases. You have to do subperiosteal dissection. This is C2 spinous process. This is top, this is below. This is the lamina, this is the pars. And you have to expose subperiosteally. You see here, I have exposed the C2 ganglion. If you have seen it, you see this was completely unedited. This venous bleeding will occur, and this can be quite severe. But I have to tell you that coagulation is not an issue in this. You cannot coagulate this venous bleeding. Sometimes, of course, you can coagulate. Then this subperiosteal exposure right to the joint. You see, this is subperiosteal exposure. Open the joint. This is the C2 ganglion. Nowadays, I do not cut it. This is an old video of mine, and I will show you that I have cut actually the ganglion. You see this. This is the ganglion, and it occupies quite a bit of space. And sometimes, particularly in cases of assimilated atlas, it can disturb your vision. So visual, you have to expose the whole region. I have cut the C2 ganglion here, as you have seen. I will not say that you should cut it always. I will not say that I cut it always. I cut it in very rare situation where I'm doing basilar invaginations and things like that. And when I'm doing very high basilar invagination, I need to cut, and that too I can avoid. You see, now I am exposing the C1 facet. These are not edited. My movements are a little bit fast. This is not fast tracked. You see, I am opening the joint and widely opening the joint. This has to be done always. If you cannot do this, the best thing is it may not be a good idea to do this, because the complications of craniovertebral junction surgery can be quite huge. So if you are doing this operation, you have to be well prepared to open the joint. You have to understand the anatomy of this area. You have to understand the problems of this area. You have to understand the venous bleeding that can be quite dramatic in this area. You have to be prepared to control the bleeding. Particularly in cases with syringomyelia, the bleeding can be huge, it can be massive. And you have, you know, I am not saying that I have been able to completely do on both sides, but if you do one side strongly, you may avoid doing the other side. But I'm not saying that you should not do both sides. But if it is, the venous bleeding can be so troublesome in these situations that you may have to do only, you know, you have to be prepared. Now you see the Atlanto-axial joint is very well exposed. The facet is open. The other most important step in this operation is to introduce bone graft within the joint. You have to do it. Means there is no compromise. If you say that I will compromise on this surgical step, I personally feel that it may not be a good idea. You have to open the joint, and you have to, I use iliac crest bone graft. In all cases, we have discussed about spacers, and I use spacers in some cases, and now those spacers I use only quite rarely. Once I have introduced the bone graft, then I prepare, and this bone graft has to be elaborately introduced. Then I prepare for instrumentation. You see, I drill the pars and the region of pedicle of this area quite elaborately to introduce to be able to do instrumentation. And place my plate and screws. I used to do plate and rods, but I have recently completely abandoned rods and screws because they are not the best form of this. You see here, then this is the facet of C1, and then I make a guide hole in the C1 facet. C1 facet, I am making a hole. This is not such a dangerous thing. There is no vertebral artery in the C1 facet, so you can introduce this safely. And as I have mentioned to you, C1 facet is the strongest bone next to teeth. This is the next to teeth hard structure in your body. And if you have realized, you know, when the person is burnt in India, we burn the dead bodies. And after the dead body is burnt, only two bones remain. One is teeth remain, and one is the facet of atlas remains. And you collect, when we collect bones of our dead people, we collect the bones to throw them, not throw, but to place them delicately in river Ganges. This bone remains. So C1 facet is the strongest and safest bone. And then we prepare for C2, introduction of C2 bone screw. And then C2 has to be medially and under direct vision. First, we isolate the vertebral artery. Then you introduce the guide hole in the C2 pedicle here, because, and in this direction, you see in this direction, the C2 screw has to be introduced. And then you turn the plate and then tighten the screw. So this is my technique of C1, C2 fixation. And I have to tell you that now in the current neurosurgery, in the contemporary neurosurgery, you cannot say that this technique, you know, we have to learn this technique because the indications are widening, and indications for Chiari malformations are 100%, indications for spinal dorsal kyphoscoliosis are 100%, indications in multi-level spinal degeneration 100%, in OPLL 100%. So there are indications are widening, and you have to learn this C1, C2 fixation. My experience is now more than 2,700 cases, and I have to say that this is a absolutely new life to these patients. So you have to then tighten the screws. The video still runs. I don't want to take too much time because Naren has said that I have to open for questions. Just the last part of the operation I will show you. The last part is also the very important part. You have to remove all the soft tissues, cut sharply the soft tissues, then drill widely. These soft tissues have to be drilled, and the spinous process, the lamina has to be drilled widely and elaborately. Then you have to drill the arch of atlas elaborately and widely. If you do not drill, then the muscles have the power to break your implants. And after you have elaborately drilled, you put a lot of bone graft here and then do the closure. I do closure of the muscles first and then of the skin in 2 layers. No drain. I use collar for the period of 2 months, restrict neck movements for 2 months, do physiotherapy of the hands and legs during that time, and then do fix, and then ask the person to mobilize as much as possible. So that's my operation. Thank you very much, my dear friends. Ladies and gentlemen, I hope you have enjoyed it. And I have to say that if you have learned it, all right. If you have not learned it, please learn it, because this is absolutely important. Thank you very much.
Thank you very much, Professor Goel. It was a fantastic masterclass in every way.
Naren, are you with me?
Yeah, there's a couple of questions. I think one question from Dr. Schroeder. She's asking that whether you have seen any aseptic wound infections with bone graft.
No. Bone graft, you know, there can be infection in all neurosurgical procedures.
Yeah.
It can be infection in shunt. Infection can be, you know, we have to know how we can avoid infection. The most important thing is infection can occur. You know, my situation, my feeling is that if you coagulate too much, more than it is necessary in that area, the problem of infection can be there. And I have to give you one statistics, Dr. Schroeder. You are a senior neurosurgeon. One statistics I am giving you. I have mentioned that I have done more than 2,700 cases. I have never removed an implant in my lifetime. I have never had a situation where pus is pouring out of the wound and you have to then go and reopen the wound. I've never had. And I relate that kind of thing to non-coagulation and quick operation. That is my understanding of this subject regarding infection.
That's great. Thank you, Prof. Prof, I'm just going to rattle quick questions for the...
Naren, I want you to first comment yourself. I want to hear your comment because I value your comment and your judgment of what I have said.
I think from what I have I have had colleagues who have done your operation and they have found it very improved difficult cases even when there was no bacilli invagination. So I myself haven't done C1 C2 fixation for Chiari with bacilli invagination. Certainly my colleagues have done it and they have said that it has improved. So I have great respect for what you are saying. I think it's a masterful technique. Quick questions, Prof. In terms of in terms of how, at what stage of your career, how many operations or spine fixations you have to do before you go to C1 C2 fixation? Because as you know, fools can go in via angels dread to tread, and sometimes there's you have to show that you are you can do things. But what's your wisdom of the wise?
See, to answer that question, you see, it is not that only senior people can do and junior cannot do. Even a junior who is talented and experienced and has learned the anatomy can certainly do it. You will be, you will be amazed. I described this technique when I was 27-year-old or 26-year-old. In 1987, we described and we did the first case in, even when the Steffi was describing lumbar screws and all those screws. So it is not that you have to be highly experienced, but you have to have that kind of a passion. You have to have that kind of, zeal. Yes, possible, I will do it, and I have to do it. And then you learn the technique, you read the papers, you go and see if somebody is doing. It is not that only senior people have to do and juniors cannot do. It is not that. Junior, senior is not the issue. It is the thing in you that will matter. And you have to, there is, as far as you said, this has to be learned. There is no excuse. You cannot say, I will not learn and I will not do because it is difficult. Difficult does not mean impossible. I do 6 cases a day sometimes. I do in 45 minutes, one case or even shorter period of time. So not that it is not doable. It is doable and absolutely doable.
In terms of cadaveric work before image guidance, that's my question as well. In terms of
image guidance, cadaveric work is very important and very important for every neurosurgery, whether it is cranial neurosurgery, whether it is brain stem neurosurgery, whether it is brain neurosurgery, whether it is skull-based neurosurgery. Cadaveric dissection will take you where you want to go. There is no question about it. Second thing is about navigation in this technique. Navigation can be used, and navigation can be effectively used, particularly for those who are not very experienced or in this kind of C2 screw insertion. But I don't use navigation. I have navigation in my department for more than 15 years. I must have used it once or twice initially. I don't use it, but I will recommend those who are doing early in their experience, I will recommend the use of navigation. It is a good tool. It is a fantastic tool. You must use it for C2 screw if you have some issues.
That's brilliant. Thank you very much, Professor Goel. It was a fantastic talk, and it was great to see your operative video. I'm sure it will be a very useful reference. Thanks to everyone on behalf of everyone.